All and thanks Roshni.
Hi.
Hi.
Can you put it on? Good. Right. Go ahead, Ghanshyam.
Yeah, thank you, sir. Thank you. Very good morning, sir. So this is an updated OS and PDL subgroup analysis of patients with extensive small cell with Atijo, Carbo and Etoposide. This is IM power 133. We know that the initial pivotal trial got published in 2018 in the NEGM, and this updated got this year only in the JCO. So we have already heard about small cell. So 2/3 have an extensive stage disease, poor prognosis, 5-year survival doesn't reach even a double figure. So platinum chemotherapy combination with etoposide, either carbo or cisplatin, has remained a standard for more than 2 decades. So despite initial high response rate, median survival is limited to less than a year. So only the immune checkpoint inhibitors has shown improved survival in 2 phase 3 studies. We have already heard about the updated Caspian with durvalumab. So we'll talk about the IM power 133 with atezolizumab. So this is the pivotal trial got published in 2018. So this was atezo in combination with carboplatin and etoposide as compared to carboplatin and etoposide as a first line treatment for an extensive stage small cell. So we are looking at an updated finding at a pre-planned OS analysis of IM power 133 representing an additional 9 months as compared to Caspian, where we are looking at 11 months of follow-up from the primary analysis. So this was the pivotal study. You can see, so carboplatin was used as an AUC of 5 and etoposide 100 milligram per meter square for day 1 to day 3, and atezo as a 1200 milligram flat, 21 days. So every 3 weeks, 4 cycles followed by atezo maintenance. So you can see the survival, the PFS and OS. So there was a benefit in the pivotal trial. And on the left hand side, so OS and PFS by tumor mutational burden. So whether it was less than 10 or more than 10, less than 16 or more than 16. So the median OS and the median PFS. So all this got a benefit. On the right hand side, we can see the toxicity. Even after adding atezo to the combination chemotherapy arm, the safety profile of this combination was not very different. So there was no added toxicity in terms of numbers or the severity. So coming to the updated analysis, so you can see, so initially 526 patients, so randomized to 403. Ultimately, in the atezo group, so around 200 patients were included for safety analysis, and similar numbers in the placebo group also. So coming to the intent to treat patient population and the ISC PDL1 and the BEP, that is biomarker evaluable population. So PDL1 expression in small cell, unlike non-small cell, is highly variable from, if you look at the literature, 2 to 83%, depending on the assay and the scoring algorithm. So in this study, SP263 was used, and if you see the prevalence of PDL1 expression more than equal to 1% on either tumor or the immune, so it was 53%, whereas more than 5% was 21%. So in small cell, so the PDL1 expression was more frequently observed in the immune cells rather than on the tumor cells, which was different in NSCLC, which was observed both in the tumor and the immune cells. And this was also seen in the Caspian study. So on the right hand side, we can see both the populations. So almost similar, and we can see there were baseline around 10% of patients who had a brain metastasis were also included. So coming to the OS, on the left hand side, we can see at 12 months 52% versus 39%, which was favoring the atezo group, and at 18 months, so that was 34% versus 21%. If you look at the median OS, 12.3 versus 10.3, with a hazards of 0.76 and a p-value of 0.015. On the median OS, you can see the waterfall. So the females probably did better. Even the elderly patients, more than 65, you can see. So the diamonds are more on the left side. So and brain metastasis as expected, so they did worse. So the surprising that liver metastasis also patients did well, as like the patient who did not have a liver metastasis. So TNB high or low, less than 10 or more than 16, so they almost did the same. If you look at a particular the PDL1 IC the biomarker group, so if you see TC or IC more than 1%, again, or confirmed overall response rate of 52%. And if you see the less than 1%, again, so 75%. So if you look at the PDL1 expression more than 1 or less than 1, so nothing much difference, so not a significant p-value. Even with the PDL1 of more than 1%, though numerically it looked more, but it was not as significant as the statistics goes. So if you see the subgroup analysis for PFS and OS, so again you can see it favored the atezolizumab and the carboplatin etoposide group as compared to the only chemotherapy backbones. So to conclude, so with a follow-up of 22.9 months, so it continued to demonstrate an improvement in OS with atezolizumab plus carboplatin and etoposide, similar safety profile compared with placebo plus carboplatin and etoposide, although the PDL1 analysis were limited to the subset of the intent to treat population. No numerical difference in efficacy outcomes were observed across the PDL1 ISC subgroups. So clinical benefit was observed in first line atezolizumab plus carboplatin and etoposide independent of the tumor mutational burden or the PDL1 biomarker status. So this has now become the new standard for those who can really afford this drug. Thank you so much.